You imagine a patient, all right? A 20 to 30-year-old patient comes to your clinic and you see that he has a big swollen toe. That is the first toe of his leg. And what do you think? Yes, you were right. The patient has gout. So what do you mean by gout? Gout is nothing but it's a metabolic disorder which is characterized by hyperuricemia. So you might think that okay, it is hyperuricemia. So what are the normal uric acid levels in the serum? So normal uric acid levels in the serum range from 2 to 6 milligrams per deciliter. So if the patient has gout, so what will be the serum uric acid in his plasma? It will be more than 6.8 is considered as a cutoff, and more than 6.8 mg per deciliter is known as gout according to the Robbins pathology of test form. So how do you actually classify gout? Gout can be classified either primary or secondary. So firstly we'll go over the basics of gout, and then we'll follow it by classification of anti-gout drugs and what are the drugs used in the anti-gout pharmacology. So welcome guys, welcome to the whiteboard doc. So how do you classify gout? Gout can be primary or secondary. Okay, what do you mean by primary? Primary is due to enzyme deficiency. So primary is mainly due to enzyme deficiency. What do you mean by enzyme? Which enzyme deficient will lead to the gout pathophysiology? It is HGPRT. That is hypoxanthine guanine phosphoribosyl transferase. This enzyme deficiency, actually this enzyme helps in breakdown of the purines into other metabolites. When this enzyme is deficient, most of the purines will get converted into uric acid, which will lead to elevated plasma levels of uric acid in the blood levels of the patient. So this enzyme deficiency is the primary cause. This can be either partial or it can be complete deficiency. Partial deficiency, we have no problem. The person might have acute attacks of gout on and off. So if the person has complete HGPRT deficiency, it is known as the Lesch-Nyhan syndrome. Lesch-Nyhan syndrome. Okay, mostly the patient suffering from Lesch-Nyhan syndrome will have more CNS manifestations compared to the gout. So these are the primary causes of gout. When it comes to the secondary causes will tell when there is increased cell turnover. So whenever there is increased cell turnover, we see elevated levels of nucleic acid in the blood, and these elevated levels of nucleic acid, that is of course the purines, are converted into uric acid, and this elevated uric acid leads to gout. So the secondary causes are leukemia, lymphoma and polycythemia, and what happens in this? There is increased cell turnover which leads to increased nucleic acid synthesis and further increased breakdown of purines into uric acid. So this leads to gout in secondary cases of leukemia, lymphoma and polycythemia. It can also be due to drug induced. What are all the drugs that lead to hyperuricemia? These are nothing but as thiazides. So these drugs basically inhibit the uric acid excretion in through the renal system. It could be furosemide, it could be pyrazinamide, or other drugs such as ethambutol as well as levodopa as well. So these are the drug induced secondary causes of hyperuricemia. So these are the basic classification of gout. All right. So this is the meaning of gout, and the normal levels of uric acid range from 2 to 6 mg per deciliter, and more than 6.8 leads to gout. So moving on to the classification of anti-gout drugs. So I have covered the complete gout mechanism and pathophysiology along with clinical features in a separate video. Make sure to watch that and come back here so that you will have a better understanding of what is gout and how do we actually treat it. Moving on to the classification of anti-gout drugs, we can divide them into acute gout and chronic gout. Acute gout and chronic gout. Acute gout is when the patient has a first attack in his lifetime, that is called as acute gout. And when this person has acute gout over and over the time, such as the first episode comes now, and then the second episode comes after some 4 months, and then the third episode comes after some 2 months. So these frequent acute gouts will lead the patient to formation of chronic gout. So this is the difference. The classification of anti-gout drugs, we have drugs for acute gout and we have drugs for the chronic gout. What do we use in the acute gout? Acute gout, we can use NSAIDs, that is the non-steroidal anti-inflammatory drugs which help in pain relief. We have another drug called as Colchicine, which was the first drug used for gout, that is in 1763. And we also have corticosteroids for the acute gout. And what about the chronic gout? Chronic gout, we have two groups of drugs. One is called as uricosuric, and the other one are called as the synthesis inhibitors. Uricosuric, they help in increased excretion of uric acid through the kidney, and synthesis inhibitors are those drugs which will help in prevention of synthesis of uric acid from the xanthine or hypoxanthine. So what are the uricosuric drugs that we have? So uricosuric drugs that we have are probenecid, and then sulfapyrazone. So what are the synthesis inhibitors we have? These are the most common, that is allopurinol, and then the newest drug, that is the febuxostat. So these are the synthesis inhibitors. So this is how you classify anti-gout drugs. It can be acute gout, in this which we use NSAIDs to for the pain relief. We also have a second drug, that is colchicine, which was the first drug used for anti-gout, that is colchicine, and we can also use corticosteroids. When it comes to chronic gout, we can have two groups of drugs, that is uricosuric and synthesis inhibitors. Uricosuric are those drugs that will increase the excretion of uric acid through the kidney, and synthesis inhibitors are those drugs that will help in prevention of synthesis of uric acid from xanthine and hypoxanthine. Examples of those are allopurinol and febuxostat, and uricosuric drugs we have probenecid and sulfapyrazone. So what are the drugs used in acute gout? What do you mean by acute gout? As I just told you, that a 20 to 30 year old patient comes with sudden onset of severe pain in the first toe. So that is the classic example of acute gout. So acute gout is nothing but it's a sudden onset of severe inflammation in a small joint. Most commonly used joint is the first metatarsophalangeal joint, that is the big toe of a leg. So which are the first class of drugs that we use? That we use are the NSAIDs, that is the non-steroidal anti-inflammatory drugs. Examples of these drugs include Naproxen, piroxicam, diclofenac, Indomethacin, and toricoxib. So these are all the NSAIDs that we use in a acute attack of gout. So how does these NSAIDs actually help in the relief of acute gout? We'll look at the mechanism of action. So as I just told you, these are the strong anti-inflammatory actions. They have strong anti-inflammatory actions, and this leads to inhibition of chemotactic migration of leukocytes into the inflamed joints. As you can recall from the last lecture of gout, as I just taught, that the gout is due to accumulation of these urate crystals in the joint space, and this accumulation leads to chemotactic migration of leukocytes and macrophages into the joint space. So this leads to the increased inflammation and pain. So what does this NSAIDs do? They actually inhibit the chemotactic migration of leukocytes into the inflamed joints. This leads to reduced inflammation and finally pain relief for the patient. Hooray, we have achieved what the patient wants, that is pain relief. So what is the mechanism of action of NSAIDs? They have strong anti-inflammatory action, and they help in inhibition of chemotactic migration of leukocytes into the inflamed joints. This leads to decreased inflammation and then pain relief for the patient. So how much do we give? These NSAIDs are commonly given for up to 6 to 8 weeks, and then they are later substituted with the uricosuric and synthesis inhibitors drugs. So whenever the patient has acute gout attacks for over the course of years, what we'll do, we'll give it continuously for 6 to 8 weeks, and in these 6 to 8 weeks also we will start the patient on uricosuric and synthesis inhibitors as well, because uricosuric and synthesis inhibitors will take time to achieve normal uric acid levels in the blood. Until then we have given the NSAIDs to control the acute gout pain, that is for 6 to 8 weeks. So another class of drug that we use is the colchicine. So colchicine was the first drug that we used for a gout attack, that is in 1763. And what do you think the colchicine will actually do? It's actually derived from it's an alkaloid which is derived from Colchicine autumnale plant. So it is neither analgesic, so it does not prevent the pain. It is nor anti-inflammatory, and it does not inhibit synthesis, as well as it does not promote excretion as well. So as you just see that it does not belong to any of the classification that we just did for anti-gout drugs. So how does this colchicine actually help in the prevention of acute gouty attack? So what does it do then? So it has a specific function, that is it has a specific suppression of the gout inflammation. So the mechanism of colchicine is it has specific suppression of the gout inflammation. How does it do this? So proper mechanism of action of colchicine is it inhibits the release of chemotactic factors and of the glycoprotein. It inhibits the release of chemotactic factors and of the glycoprotein, further leading to suppression of release of the lysosomal enzymes. This is by binding to the fibrillar proteins and tubulin. So the colchicine inhibits the release of chemotactic factors and of the glycoprotein. It further suppresses the release of lysosomal enzymes by binding to the fibrillar proteins, that is tubulin. This leads to suppression of migration of leukocytes and macrophages. So whenever the migration of leukocytes and macrophages are suppressed, this leads to suppressed inflammation, or inflammation is decreased, and finally the patient has pain relief, that is hooray. he doesn't have pain anymore. So this is the classic mechanism of colchicine, that is the inhibition of release of chemotactic factors and of the glycoprotein. This suppresses the release of lysosomal enzymes by binding to the fibrillar protein, that is tubulin, which further suppresses migration of leukocytes and macrophages, which suppresses or decreases inflammation, and finally the patient has pain relief. Hooray! So wait, what about the pharmacokinetics of colchicine? It is rapidly absorbed from the oral. So the oral tablet is rapidly absorbed and it is further metabolized in the liver and excreted via bile. This bile, it can go either through the urine or through the feces as a stercobilinogen, and in the urine as a urobilinogen, just like that. Okay, and we know that the bile undergoes enterohepatic circulation. So more and more enterohepatic circulation will lead to colchicine toxicity. It is metabolized by CYP3A4, that is a cytochrome P450 3A4 class of enzyme. So whenever there is CYP3A4 inhibition, this leads to colchicine toxicity. So what about the side effects of colchicine? Yes, it does occur. It can be mild as well as severe. So mild side effects include nausea, vomiting and diarrhea. Diarrhea could be watery and as well as bloody. So what are the severe side effects of colchicine? It leads to severe kidney damage. It acts as CNS depressant. It might lead to intestinal bleeding, and death due to colchicine is mainly due to muscular paralysis or as well as respiratory failure. So these are the severe side effects of colchicine. So how much colchicine do you have to give if a person is suffering from acute gout? Normally we will give 0.5 mg over 1 to 3 hours, total of maximum 3 doses. Max out we can give 6 mg over the course of 3 to 4 days. For maintenance or prophylaxis, we can give 0.5 to 1 mg per deciliter till the long acting, that is the uric or synthesis inhibitors take place. Do we have another third class of drug for the acute gout? Yes, as I just told you, we also have corticosteroids. So how does corticosteroids act in this? The mechanism of action of corticosteroids is when we give intra-arterial injection of soluble steroid, it decreases the symptoms of acute gout. So basically corticosteroids, as we just know that steroids will actually decrease the inflammation. So what we'll do in this case, we'll give intra-articular injection of soluble steroid which decreases the symptoms of acute gout. Can I give systemic steroids in this patient? Yes, we can give, but it is rarely needed. Whenever we can't give these above two class of drugs, that is NSAIDs and colchicine, are contraindicated, we can give systemic steroids. So these are specifically reserved for renal failure patients as well as a history of peptic ulcer disease. As we know that peptic ulcer is a common side effect of NSAIDs, and if the patient is suffering from peptic ulcer disease, we can give systemic steroids. And we know that the colchicine will cause renal failure. So in renal failure patients, we can't give colchicine. So if those two classes of patients we can't give, we can give the systemic steroids. If I'm choosing systemic steroids, which drug I'll choose? I'll preferably give prednisolone, that is 40 to 60 mg per day in tapering doses over the weeks. So now let's move on to chronic gout, and we'll have a separate lecture on chronic gout, the separate class of drugs and their mechanism of action. And before we end the lecture, let's wait for the thought of the day. Always be ready to say goodbye to anything, because self-respect is more important than feelings. Every fail is a chance to rise. Thank you guys. Thank you for watching. Have a good day and subscribe and share this if you feel this important enough. Thank you.